Hi everyone, welcome to researchmd.com. Great presentation today. We're going to teach you everything about how to treat diabetic ketoacidosis. Okay. Again, my name is Pramil. Cheriyath. I'm a program director, internal medicine residency, transitional residency. I teach medical students and residents on a regular basis. I'm also a director of research, and I hold 2 assistant professorships at 2 large medical schools. Let's get into our topic. So when you talk about DKA, you can have you can also call it like a diabetic. The main definition is pretty much you got a blood sugar greater than 250. pH is less than 7.25, bicarbonate is less than 15, okay? And then DKA can lead into several complications, hyperosmolar, hyperglycemic coma, and all of those kind of things are the major complications. They can have arrhythmia, sudden death, even myocardial infarction is also very common. So these are the major findings. You can define DKA into 3 topics actually: mild, moderate, and severe, based on that. It's a nice classification there, but always going to remember the major classification. The major definition is like blood sugar less than 250, greater than 250, pH is less than 7.25, bicarbonate is like less than 15, okay? But again, you can define into the newest classifications, say mild, moderate, and severe DKA. So what are the treatment goals? Always the number one, restore intravascular volume, prevent correct electrolytes, correct acidosis, and correct hyperglycemia. Those are the major plans, like the major goals of treating DKA. So IV fluids, it expands the intravascular, interstitial, intracellular volume, lower blood glucose, improve blood pressure, ensure perfusion of the peripheral tissues, and it facilitates resolution of the metabolic acidosis. So IV lights are the first line treatment. You can give normal saline 0.9%, and you cut. IV fluid choice can be if the corrected serum sodium is high or normal, then you can use the half normal saline. And if the corrected sodium is low, you can put normal saline at 250 to 500 ml per hour should be given. And the bicarbonate therapy, there is not significant role bicarbonate therapy. Studies have shown it can actually damage the tissues, can cause tissue death. So the only time the current recommendation, if you do a pH, that's why in DKA we do a blood pH, right? If the pH is less than 6.9, and then you should be giving bicarbonate. Remember that. Otherwise, the pH is 7.2, 7.3, or 7.1. There's no role for bicarbonate. Remember that. Potassium, okay. After establishing adequate renal function, potassium can be given. If the serum potassium is less than 3.3, start fluid replacement first and then replace the potassium prior to giving insulin, okay. And then if the serum potassium between 3.3 and 5.2, give potassium, and then IV fluid, and you maintain around 4 to 5. If the serum potassium is greater than 5.2, make sure you don't give any supplemental potassium, but make sure you check frequently the potassium level. Now, magnesium should be given if the serum magnesium is less than 1.2 or less than 0.15. Less than 1.5. Phosphate should be considered in patient with the serum phosphate level less than 1, cardiac dysfunction, anemia, respiratory distress, and other respiratory depression also. So the main treatment also in DKA are insulin therapy, right? What does it do? It suppresses ketogenesis, reduce blood glucose, and correct electrolyte disturbances also, right? And I think initially the first thing we should think fluid resuscitation initially, and then promptly start that, and then you can start the insulin, and you correct the hypokalemia also. Okay, insulin administration, again, make sure that you start the fluid first, and then correct the hypokalemia, and then you promptly start the insulin. Now, is there a difference between the subcutaneous insulin drip? Recent studies have shown that not much difference. So if they're a mild DKA, or you can treat with, it does not have to be insulin drip. You can do subcutaneous insulin. Okay, we got a nice diagram explaining each step, the importance of treating, importance of treating how to treat DKA, right? Okay, next one, you got prevention. I got a preventive strategy. Make sure you make sure identify the high-risk people. Who are the identified high-risk people? Low socioeconomic status, adolescent age, female sex, and ethnicity or migration. And modify risk factors like previous DKA, high HbA1c, alcohol, drug abuse, poor quality of care, and then make sure you have like a diabetic self-management education and medical psychological intervention or digital approaches, and all of this can help to prevent it. These are our references. Thank you so much for watching. We'll be back with another presentation soon. Please subscribe to our channel. Thank you.